It's not by chance that the first session of the Global Health Forum is Innovations in Health Systems. Part of it is a personal bias because originally I'm a professor of health systems. So there's a personal bias, but also because whenever we want to start forums like that, you want to put your A team or people that you really respect at opening sessions. Not that any of the people in other sessions are not A teams. But it's again a personal bias. So it's a pleasure to have our distinguished speaker be on the panel. The additional benefit is that few of them are friends of AUB, friends of the Global Health Institute, and friends of mine. So it gives me great pleasure to welcome our speakers. The issue, as Mr. Lazzarini said, the issue of innovations in health systems is one of the key challenging. He spoke about financing of health systems, introducing approaches and innovations in that. We're going to discuss also human resources, health systems development, and quite a bit of experience that Salman has. So we will start off by Dr. Salman Roth. Dr. Roth is the director of the WHO Collaborating Center for Public Health Education and Training at Imperial College, and is an internationally recognized figure for his work and contribution to global health. He is an advisor to WHO on primary health care, public health, health systems, medical education, and human resources. Professor Roth is also a fellow of the Royal College of Physicians at London and a member of the Faculty of Public Health Medicine, Ireland. He is the UK Faculty of Public Health Global Health Advisor and executive member of the International Committee of the UK Academy of the Royal Medical College, and a member of the WHO Advisory Committee for Health Research. Salman has quite a bit of rich experience addressing global health in so many different settings. It's a pleasure that we have him here, and we're looking forward to his talk. Salman, the floor is all yours.
We're delighted to be here in Beirut. Beirut is the place which I love. It's reminded me of my childhood. It's always a pleasure to be here, and I feel very happy when I'm in Beirut. I don't know why. There is some sort of chemistry with this country. When we talk about fragile health systems, I believe we are always in catch-22 for somebody like me in the academic world and involved in over 50 health systems around the world. Because when it comes to research on fragile health systems or health system in a fragile setting, whatever terminology you want to use, there are very, very little literature which we can refer to. So I'm sharing with you some of the research findings, but also my experience in many countries. And we shouldn't forget we are living in a region, I would say about half of the countries are in fragile setting. At least I can identify to you 8, but I'm sure my team back in London, they will say there are maybe 12 or 10 fragile systems. Some of them are truly fragile, some of these systems are on the borderline. I'll touch on these things very quickly, but we exist, whether we are in medicine, in public health. I'm a physician. My job is to prolong people's life. My job is to make sure that they live free of disease and disability. And my job also is to ensure that their quality of life is one of the highest. I'm not here to treat disease. I mean, anyone sitting in a hospital and saying I'm treating disease, he is absolutely an idiot, because the first starting point should be maintaining health. And therefore, that focal point in how we shape systems and how we shape our contribution to system, and as Philippe said, how important primary care in saving life and promoting life, and the figures which he gave us absolutely prove to that. This is a slogan, and I make sure everyone actually study, learn at Imperial, say, look, this is what I'm trying to achieve. And when it comes to fragile health systems, or health system in conflicts, again, another definition. We need to know we are talking about something which is unpredictable instability. I remember when many years ago, not many years, just a few years ago, celebrating 150 years of the existence of this great institution, there was a meeting by the Faculty of Health Science on fragile system, on actually unpredictability in public health. That was what was it. But unfortunately, that unpredictability become a norm for many people who are living in these countries. And this is what we describe, the new norm. And it's accepted by politicians, accepted by NGOs, accepted by a lot of people. We have today 1 billion people living in a fragile setting around the world. We have 60 million people displaced. In this region alone, about 25 million people. 1/3 of all maternal mortality are in these settings. Half of the child death in the world are in these settings. And death due to violence and men, actually, which is more than women, of course, because of wars and conflicts, are actually unbelievable. We know that the death from 2003 until last year, which we published it recently, in Iraq alone, about 500,000 population. So you need to know the magnitude. We are talking about loss of life, discomfort to many people around the world. When I look again, decanting the experience and the evidence and literature, I will see a variety of things here. Doesn't show that one. Increase in need because of the violence. Disrupted family life. I don't want to go through all of these, but look at the red circle in the middle. We are talking about missing generation. This is a term I'm introducing for you to remember. These generations are missing on a lot of things, which all of you sitting here take it for granted. And I don't want to go through this because I want you to think about that. And I want you to be in Yemen today. I want you to be in Syria today. I want you to be in part of Iraq today. And think how the people are living. And your child with you, 10 years old. And yet, we don't think about solution or finding solution. And again, when we move a little bit ahead, and I don't know what happened with this. Again, there is a huge degrading of social capital, damaging the infrastructure of the country, education, health, etc. From 2003 until now, Iraq, for example, which I'm glad Dr. Adham is here, WHO representative of Iraq, and Naima Qasir is here before him. She done fantastic work, and I'm sure Adham follow that steps. Until now, there are classes which students sitting in crowded classes on the floor, yet trying to learn. And we've seen the experience of 70 years in Palestine. What we do, what should we do? And what we have done in many countries around the world. Because of the time, I'll be very quickly. I look at this in 3 stages. During the conflict, mainly humanitarian responses, just to respond. Majority of the work by international organizations, by neighboring countries, by NGOs. Post-conflict, it's great opportunities for countries who actually, beyond conflicts, to be able to rebuild a new system, a new thinking, a new idea to compensate for the loss. And then long-term stability, how tragic I can build something which is totally different than it was before. And let me look at the major resources which we use to establish that resilience in the health system. And I divided these into 5. I mean, you can add as much as you can. And these actually rely on the technology available to us, and thanks God that is moving fast. This is important innovation. But also building that social capital which is degraded, as I show you. At the end of the day, providing services which meet the need of the population. Very quickly, the major issues in relation to family and social network, that disruption to the family and social network is mentioned there. But the innovative solution which we need to think about, how to encourage local and national NGOs to participate in building that relationship and building that network in families. Again, we tried it in many countries, and I will say one word or two about international NGOs. Put them under clear governance. The abuse of women and children by international NGO is absolutely scandalous. And we know now it's open, and some of them apologize, but I'm delighted my government actually stopped funding from some of these international, what is called NGOs. And I always surprised why people volunteer so lightly about these, etc. I don't want to spend much time on it. We talked about these, some of the NGOs in West Africa. We documented that in some publication. We talked about the role of NGOs in other countries. We documented that in population, and I want you to go in the literature and find it. Using the media, the social media, when internet is available, it's a very important tool. Actually, there are a few studies happening in my department looking at that, how connecting families in a fragile system, and encouraging some of the places in Yemen, some of the places in Somalia. That connection is a very good opportunity. And also, should read other media to connect, television, radio, etc. When we come to innovative financing of the health system is one of the most problematic things in the fragile health system. And we need to think carefully, and we need to find some solution. In Cambodia, for example, they found that the health equity fund was the best method, at least in the first 4 or 5 years, and it did work beautifully. But also the community-based health insurance, it worked much better than relying on funding from outside, which wasn't stable. They managed to stabilize the system very quickly and moving into much more stable finance. So there are some innovative approaches in funding which we need to look at. Human resources will be the major problem because the majority of them displaced, the majority of them leaving the country looking for other jobs. Some of them are even killed. We've seen what happened to human resources for health in Syria, and the attack on health establishment. Actually, the AUB is leading with the Lancet Commission on Syria, some of the pioneering work, and we congratulate them on that. But you need to look at, even if you have a small number of health resources, human resources, you need to think how to redistribute it. Because again, in some of these fragile countries, they stayed in the capital in one place. So think about that, and there are a lot of good examples. The institution, rebuilding the institution is a major task. Because the first things to dismantle, and the American and the British in Iraq, the first things that they did, dismantle every institution. It was by order, abolish the army, abolish Ministry of Health, abolish rebuilding it is a nightmare. Until today, the Iraqi institutions are suffer. So communities, again, they are the solid background for rebuilding the system, because the people who are actually suffered from war, conflict, are this community. I have a lot of signals now, I need to shut up, But you need to think about recruiting people from the same community. Let the leaders in this community to lead the rebuilding of the health system. This is not about somebody come from WHO or from United Nations and say, go and do this and that. This is the drawing of the system. No, this is actually, bottom up. Rebuild it in a proper way. Last but not least, these my 4 I's. Include everyone. Don't exclude it because this is Shi'i, this is Sunni, this is Maroni, this is blah, 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 etc. This is pathetic. Everyone should be included in the rebuilding process. Invest in a human being, in resources, institution building. Innovate. Think about something nobody thought about. Don't just copy. There are a lot of opportunities to sit down and reflect and think. Integrate whatever you have. The vertical programs, and in one of slide I did show it, one of the disadvantage of the rebuilding process is the vertical program. And when we looked in West Africa and the source of Ebola, we found and we documented that because of the Gates Foundation funding of the AIDS program and the AIDS services, they managed to destroy the mainstream services. Again, you need to be very careful of international funding that should be to the mainstream, not vertical program. And these are, in conclusion, innovative approaches, use all means possible, think about international NGOs, and look at international and national governance, and bring everyone together. And thank you very much indeed.
Thank you, Salman. Thanks. Thank you, Salman, for the interesting talk. Our next speaker comes to us from Thailand, Dr. Bunshai Kisanayotin. I hope that I'm pronouncing this right. Dr. Bunshai is the chair of the Asian eHealth Information Network. He is also the vice president of the Thai Medical Informatics Association. He is an informatician and physician from Thailand. Previously, he had worked in rural public general hospital for 15 years as an internal medicine clinician. His working areas and research interests are national health information standards and interoperability, health information exchanges, national e-health strategy, and health IT adoption. Currently, he is the manager of the Thai Health Information Standards Development Center at the Health Systems Research Institute at the Ministry of Public Health in Thailand. A pleasure to have you, Dr. Bunshai. Floor is all yours.
Good morning. This is my first time in Lebanon and in Beirut. It is very beautiful cities. Yesterday afternoon, I have a chance to walk around the cities, and this morning I run around the coastal of the beautiful city. Thank you for inviting me. I interpret the title of this panel, like the innovation for the strengthening health in fragile. I have a little challenge on how to interpret the concept of the fragile environment. So I come up with the thing that we think that this is the innovative thing that we do in South and Southeast Asia country to develop the network of the people in that regions to work and helping working together to help develop of the health IT or digital health to strengthening health system. So I will talk about what we think this is one of the innovation that we works in the regions. We have an Asian eHealth Information Network, which is the regional health and health IT professional or the digital health in Ministry of Health, in academia, private and international and national NGO. We commit to work and promote better use of the health IT, digital health to achieve better health and healthcare. We starting very informally in 2012. When we have a kind of the forum similar to this, they call the Health Leadership Forum, Digital Health Leadership Forum in Manila. And we found that we present our challenge and our plans to develop the national health IT or national health information system in that forums. And we found that we have the same challenge, we have the same problem. So we just coming together like six people in 6 countries. Should we come and discussing about how we're gonna help each other on that? And we're lucky that the WHO Western Pacific give us a very small grant to work on the plan. And then we can have this first general meeting in Bangkok in 2012, around 100 people. And then we can do a lot of activities helping each other what I mean helping each other, which means that each country are showing their scar. We share the failure, not just the success. And we tell our friend that we have done this, you should not do this, and then you should do another way. And that is what we do. We just finished our 6 general meetings last month in Colombo. There is about 300 people attend, about 32 countries attend this meeting. The Ministry of Health Colombo is the local host for the regional, and the international organization also participate in both WHO, UNICEF, ADB, and several are supporting the delegate to that conference. And right now, we are the open network. Right now, we have around 12,000 members. It really, there's no fee. And this is the developing partner that we are working with. All of these, they don't give the money to the network, but it seems like we align the projects and work on what we call the challenge on the digital health or health network. And we have a very small people working in. We have a representative from each country. We call the working council, and we have five people in the general committee from 5 countries working together. We have a virtual meeting every month, trying to get the activity that supported by the developing partner that can be helping each country to work on the health IT and e-health. And we're starting with this. I think maybe some of you are familiar with the e-health, WHO IT, National Statistic Toolkit. This is the guidebook that the WHO and ITU provide to the country. That the country, if you want to build the National Health Information System or the e-health or the health IT, this is the kind of the guideline, and it promotes to all the countries. And this is the 7 components that we are working on to build the National Health Information System. We found that when we come together, have a discussion, and we found that what kind of the challenge that we face, and we follow all these this kind of the model that to develop the e-health strategy. We need some kind of the capacity building in several areas for the architecture, the governance, the standard. This is 4 areas that we are working in. Mostly we do the peer-to-peer sharing and building capacities, and we work on the CRVS, and we found that every country are challenged with standard and interoperability of the health information system. Along 3-4 years, we found that every country faced the same challenge to build up the National Health Information System, and most of them is the foundation. And we call gaps. And this is the 4 areas that we found that every country need to be developed: the governance, the architecture, the program management, and standard and interoperability. So we mind the gaps and fill the gap. Mind the gap and fill the gaps model. And this is all the activity that we done in the regions. Right now we have 6 general meetings. We do webinar every 2 weeks, and we invite the international expert or even the national expert that do on this kind of the health, digital health IT to share their knowledge. And the other activity that we usually do, we call the knowledge exchange. Countries, neighbor country that, oh, I have this kind of the challenge, that kind of problem. You already done good in this area. Why don't you come and helping, working to do the workshop? And we do this in many countries, in Sri Lanka, in Bangladesh, Myanmar, and even the North Korea are also working with us in Thailand to share the knowledge. And right now, I missed the one of the important meeting they call the convergent workshop. We gather all the stakeholders, Ministry of Finance, Ministry of ICT, Ministry of Education, and also Ministry of Health, organized by the Ministry of Health, to come and work on the National Health IT or National Health Information System. The issue is not just the Ministry of Health, it's all the ministry. And we call it the convergent workshop. Right now, they are doing the second convergent workshop in Naypyidaw in Myanmar. I missed that workshop because I came for to this forum. And what we want to achieve now is to integrate the silo projects like malaria, TB, HIV, and the health management information system to work together to interoperate and work on the national health information system. And this is what we achieve. We do a lot of work, trainings, which is supported by the international NGO and developing partner. We have the demand, and we request this kind of we do the governance, we call COVID, the photograph. And we also create a lot of products related to the digital health IT, and we share. Our motto is that when we help friends will help us. We always share our failures, because many academics and many scientific conference, they have a success, but we also share failure, and we work like the peer-to-peer. And then when we help our friend, later friend will help us because of they also get in some area. Thank you.
Thank you, Dr. Bunshai. Especially adding with that statement, helping friends will help us. So our next speaker is Dr. Muhammad Alamuddin. Dr. Alamuddin is an associate professor at the Department of Health Management and Policy at the Faculty of Health Sciences here at the American University of Beirut. He joined AUB in 2008, coming from the University of Toronto, where he worked as the Director of International Development at the Faculty of Medicine. Muhammad holds a PhD in Health Management and Policy from the University of Toronto and a Master's of Public Health from AUB. His main research interests include studying health human resources, labor force dynamics, recruitment and retention practices, resilience of health systems, and the quality of work environments. Muhammad has multiple publications in the field and is regarded as a regional expert on health human resources planning, management, and quality of work environment. And he's a dear colleague of mine as well. Muhammad, floor is all yours.
First of all, I'd like to say that I'm really, truly humbled by being part of this distinguished panel. I'd like to thank Shadi and the organizers for giving me the chance to address this distinguished group this morning, and I hope you'll find the next 10 minutes, Maria, I have a timer here, helpful. I'll divide my presentation will be reflections on human resources, systems, and the topic of the morning. And it will be divided into two halves, 5 minutes on some reflections of health, human resources, labor, and conflict settings. And the next will be a glimpse on some of the recent studies that we've done on that with colleagues from Queen Margaret University. The first thing I want to do, I'd like to remind myself first, before anyone else, that we often talk about numbers, tables, figures, graphs, associations, and arrows. Behind every table, there's a child in need. And behind every figure, there's a family in a desperate situation. And behind every association, there's a population in despair. One of the mistakes that I could do, or any one of us could do, is to depersonalize what we're talking about. We really need to keep this renewable source of energy inside us so that we can keep addressing these difficult contexts. Dedication is to those refugees who are suffering. The topic of the morning is innovation. That's the definition. It's information, imagination, and initiative, and driving greater and different values from resources. Innovation could be at the input level, resource at the process level, or at other levels. Innovation could engage technology, use of technology or other resources. Innovation could be viewed as a luxury or as a value added, or could add efficiency in certain organizations. In complex and fragile settings, innovation is a necessity because innovation will enhance resilience, and resilience means survival. So it's not an option anymore. And when we talk about human resources systems without innovation, now we'll talk about some of the challenges. There's no way someone could deliver care to the needy populations. So key concepts about health human resources. In brief, I don't want to take much time here. No system can function without an adequate number of health human resources, well-balanced workforce that is well-distributed and properly motivated to deliver the best care. From a labor economic perspective, that's called the stock and flow model of human resources for health. If we think about the square in the middle as the tank that has all the full-time equivalents of human resources for health, how can we fill this tank? Well, we can fill it through new graduates, reintegration of inactive human resources for health, increase in workforce participation shifting from casual part-time to full-time, foreign trained human resources for health like the Arabian Gulf region, for example, or by enhanced skill and productivity. How could this market be depleted? Well, it could be depleted by early retirement, by immigration, by death and disability, by decreased productivity, and by decreased workforce participation. So what happens in situations of during wars and in fragile settings? Well, just imagine with me the complexity. We have a situation with diminished supply, poor supply, sometimes the infrastructure is destroyed, schools cannot graduate anymore and cannot function anymore, decreased workforce participation, less productivity, and in complex settings, no foreign trained human resources unless they are brought forward by international NGOs. At the same time, we have increased needs. So we have delayed care, people have more complex conditions, emerging challenges, infectious diseases arising again, etc., etc. And this adds, of course, complex wounds and amputations and. The third thing that happens here, we have very poor practice environments, dangerous settings, with depleted resources, with generally lack of professional development to face the new conditions, and sometimes the work environments are polarized and discriminatory. And last but not least, we have in terms diminished active HRH availability with active migration, early retirement, and more death and disability. And here I say yes, death and disability. And Dr. Salman, you alluded to this. We've published with colleagues this paper just as a scream for help. I mean, there is a systematic targeting of health facilities and health human resources who are working in very difficult contexts. So, the challenge remains, how can we sustain capacity and maintain service delivery in these difficult settings under such an impossible conditions? How to surmount the challenges of poor safety, diminished resources, and difficult accessibility? And how to continuously innovate while delivering care with little resources? I like the analogy of You know what happens? It's like driving a car at full speed on a highway and fixing it at the same time. That's what's happening. So, to reflect on these, I'd like to give you a snapshot in the next 5 minutes or less about the case of Palestinian refugees displaced from Syria with colleagues from Fuad, you're in attendance, and colleagues from Queen Margaret University. And this will appear next week in Social Science and Medicine, this work. What's happening in Syria? I think it's no secret. It's a country shattered into pieces. Around 11 million displaced, 6 million internally, 5 million externally. 1 death in 1,000 population, 1.88 million injured, and a large number of health workers killed, injured, detained, kidnapped, or whatever. And if the Syrian population is vulnerable, it's even more vulnerable those that are refugees in Syria. Yani you can imagine the vulnerability of those. What happened to them? Well, they flee to neighboring countries, and the focus of the next few minutes is on those that fled to Jordan and to Lebanon. What we've done, we used the qualitative methodological approach that blends semi-structured interviews with group model building methodology in order to construct a model that can explain some of the complexities. We wanted to understand what's happening and understand it through lots of input and through building a model. So the semi-structured interviews identify the key themes and build the seed model, and then the group model building validated and added detail and rigor, and then at the end we constructed the model that I'll show you in a minute. And we used a capacity approach to analysis with absorption, adaptation, and transformation. Absorption is when you use your current resources, human, financial, whatever it is, to address those increased and rising needs. Adaptation is when you need to infringe your system with additional resources but without changing system structure. And then transformation, you need to change system structure because the current status quo is not sustainable anymore and would not address the needs. These are some of the photos from the group model building workshops that we have done. We used rich picture activity, tracking change over time, drawing dynamics of the system. It was lots of information collected, and we discovered also the artistic skills of participants, actually. These are additional photos. That's the complete model, Lebanon model. There's another one for Syria and another one for Jordan. It's too complex to see. We appreciate that. Dr. Sita from UNRWA tells me this is spaghetti model with meatballs at the nodes. And we appreciate that it's very complex, but if you delve deeper into these models, you discover pathways and relationships that are really interesting. So, Dr. Salman is the only one that will understand it at first glance, I think. So this red circle is what I will conclude with this presentation. So what did we discover? For example, increased workload due to flow of refugees will increase staff pressure and will deplete capacity to ensure service continuity and delivery of service. So what happens? Initially, absorptive capacities at UNRWA were used, so praise and recognition, and then staff allocation and task shifting. But with the increased conflict and flow, what happened? These would not work anymore. So you need to use other adaptive capabilities, like, for example, changing the HR policy in order to be able to recruit on additional resources and new hires. And UNRWA at this stage formed something called refugee health teams, SWAT teams that could be dispatched to different centers based on need, including a physician, a nurse, a pharmacist, and a clerk. But even, with the prolonged crisis and arising needs and arising specifically psychiatric needs of the population, UNRWA transformed its system to deliver new services, mental health and psychosocial support services, and they became crystallized now as part of the UNRWA system. So that's, for example, part of the human resource reflections that we had as part of this exercise. To conclude, innovations to sustain HRH capacity in complex and fragile settings is essential for survival. We need to approach this from a dynamic, innovative way in order to address the scope, intensity, and progression of crisis. And I encourage my colleagues to look at this from an absorptive, adaptive, and transformative lens. And finally, essential to plan for and implement innovations that would enable the utilization of displaced human resources outside the geography of crisis. With this, I conclude my presentation, hopefully on time, So hopefully on time. Thank you very much.
Thank you, Muhammad, for a very interesting presentation and for good work in the area of human resources. Our last speaker is Dr. Zafar Mirza. Dr. Mirza is the Director of Health Systems Development at WHO Regional Office for the Eastern Mediterranean region. He is a medical doctor with postgraduate in public health in developing countries from London School of Hygiene and Tropical Medicine, and with a clinical stint in mental health. Previously, he was leading the public health, innovation, and intellectual property team at WHO headquarters in Geneva, Switzerland for 6 years. He also served as the regional advisor for essential medicine and pharmaceutical policies in the WHO regional offices for 5 years prior to moving to WHO headquarters. He also was the founding executive director of a civil society organization, the Network for Consumer Protection in Pakistan. Please join me in welcoming Dr. Mirza. Dr. Mirza, the floor is all yours.
Thank you. Thank you very much, and very good morning to all of you. It's very nice to be here. This is my first time in American University of Beirut, and bundle of congratulations on number of achievements that we have been hearing since this morning. Innovative approaches to global health challenges in low and middle income countries is a very broad subject, and there can be a million ways of approaching it. As you have heard from the panelists, we have approached it according to what we thought is important, or where our interest lies, or where we come from. I have a threefold presentation, my way of looking at it. I'll speak briefly about the concepts conceptually. I'll provide a practical example of one end-to-end innovation to address a challenge in low and middle income countries, and I will also provide another homegrown example of institutional innovative response in our region. As perhaps you know, and if you don't know, it's important to know that World Health Organization is fast transforming these days under the new leadership of our Director General, Dr. Tedros. And part of this transformation is also to position ourselves more explicitly and more visibly in the area of health innovation. So a three-level task force has been created. When I say 3 levels, it means headquarters, regional offices, and country offices. And I'm part of that, and we are engaged in actually developing our conceptual positioning and framing ourselves in the explosive world of health innovation, which has taken place actually around the world, but it is more concentrated in the Western Hemisphere. So when we say health innovation, what do we really mean? These days, what we mean is that new or improved valuable health policies, systems, products, and technologies, or services and delivery methods, or any combination of these that has the goal and action of improving the health of populations. So innovation, I think one of the most important, two important points here are, one is that innovation does not have to be absolutely new, which did not exist before. It can be also repurposing of something existing, and to put to a purpose which help us to achieve your objective. And secondly, generally, especially people who come from technology background, health innovation or innovation is more product oriented. Medicines, vaccines, technologies, but our conceptualization of innovation is much broader. It covers everything virtually. So this is the approach with which World Health Organization is now approaching health innovation. We have also a larger, a more elaborate definition, but I will not read it out for sake of time. Secondly, what is the aspiration here? The aspiration is to introduce a systematic approach to identifying and catalyzing innovation which focus on country needs. So that's the aspiration that World Health Organization has adopted now in this area. The scope of activities is large across all 3 levels of the organization, as I just mentioned. Addressing country needs in terms of shaping, scaling, promoting, and amplifying health innovations. Sorry? Okay, thank you. With reference to the definition that I earlier mentioned to you, so it's scaling up is also a very important dimension of health. Once you have developed something new or existing, how you scale up and extrapolate it at a wider level. Linkages and focus on multi-directionality of innovations. Let me turn to oops. So my presentation is all messed up. I don't know. I think I have saved the wrong version. But let me continue to speak. The practical example that I wanted to give you was about a vaccine which was developed and launched in 2010. And this vaccine has helped us to eradicate an epidemic of meningitis A in sub-Saharan Africa. Why I mention this and want to give this example to you, many of you might know already about this, but it is useful example because it reminds us and it continues to inspire me personally that how if a proper collaboration takes place and how if needs are properly assessed, how innovation can take place actually in developing countries and help us in addressing the needs, public health needs which are there. So in this case, until 1995-96, actually this is a figure from 95-96, 25,000 children were dying because of meningitis A in sub-Saharan Africa. This is a meningitis belt that we call, which consists of about 18 to 20 countries. And there was no vaccine available for that. This was taken up by African countries themselves. They joined hands with a number of international organizations. And eventually, to cut a very long story short, in 2010, a vaccine was launched. But the important thing here is that this technology for developing this vaccine was developed through collaboration. Manufacturing took place in India. United States, Netherlands helped in developing that technology, but also in technology transfer to developing countries. Now a couple of other countries in developing world are also taking it up. And this vaccine, once it was launched, was so effective that today, in that belt of meningitis in sub-Saharan Africa, there is not a single case of meningitis A. Over a couple of years, a whole epidemic has been eradicated. The price of this vaccine is one dose, $0.5, and the price of the same vaccine for other serotypes was more than $50 per dose. Now, this technology, when it was shifted in developing world, the cost of production went down, collaboration took place, but when a transfer of technology takes place on one particular item, it does not limit itself to that item because there is a very broad positive externalities of such transfer of technology. So I give you this example because I think that this is an example which help us to understand that if the needs are properly understood and if proper collaboration takes place, a lot of challenges, public health challenges in developing countries can be addressed. Prices can come down, technology transfer can take place, and there are huge public health dividends which can be approached. Let me move to my last part of my talk, which has become a talk, not a presentation, is an institutional response that we thought, I took up as a director of health system development in Eastern Mediterranean Regional Office of WHO 2 years ago. And one of the earlier things which I asked my colleagues and myself was that what health system is contributing to the fragile states and the emergency situations in our region. And I realized that there was not much, whereas in fragile states and in emergency contexts, most of issues are related with health systems, as we heard from Dr. Salman this morning. All 6 building blocks and everything goes wrong. Health systems are already very weak, and they become more weaker or they collapse, as we saw in the case of Ebola, for example. And the weakening institutions, bad governance, lack of financing, and all those factors actually destroy even the existing health systems which are already weak. So and the response to these from health perspective comes from emergency and humanitarian stream, which is very important, but also it has its limitations. And the limitations are that these responses are basically aimed at firefighting, quick relief. But at the same time, we have to understand that how simultaneously or correspondingly we invest in system development. To begin with, start preparing countries that how they will address emergencies if emergencies fall upon them. How during the emergency response also would take into account the health system considerations. And how, when the emergency starts gradually fizzling away, how a new system, a new health system can be built out of that rubble.
Dr. Mirza.
I'm just concluding. So the institutional response that we managed was to create a health system in emergencies lab. And that lab, and I could show you more details about this through slides, but that is one institutional example which I would very much like to also collaborate with Global Health Institute and other stakeholders sitting here, that how we can invest in health systems in our emergency situations in our region. Thank you very much, and I'm sorry for the presentation.
Thank you. Thank you, Dr. Mirza. We're a little bit over time, so we'll just give 10 minutes for Q&A from the floor. I will just start off by asking one question to the panelists, and I hope, and I have to be a dictator, and how much time I give you to answer. So many of us, when they think about innovations, especially in health systems, the first thing that comes to mind is that those innovations will be expensive. So I would like to ask the panelists, or whoever would like to respond, on examples or concepts or ideas where actually innovations in global health can be inexpensive and effective, especially that in many of our settings we are dealing with low and middle income countries. Anyone wants to?
It works.
Yes.
I would say certain innovation. I mean, when you talk about innovation, there is danger to talk about technology. Innovation is much bigger than technology. Let us make it very clear. As somebody who been involved at the top management of health system in Southwest London for 23 years, we innovated a lot of approaches in healthcare delivery that actually save money, didn't cost us money, because we accepted the traditional things of providing services and nobody dared to challenge it. Why should we need diabetic services in a hospital? If you move it, you would reduce it to about 10% of the original cost in the hospital. Why do we need bed for ENT surgery? Why do we need this? Nobody dared to challenge it. I cannot accept in the 21st century that somebody diabetic should go to the hospital immediately. This is pathetic. What you need is strong primary care. you know, with family physician, well-trained. These cases could be detected early. It's actually, you see, most of the concept of NCD now changed because we think it's not reversible, but now we know it's reversible.
Thank you, Dr. Rawaf. Dr. Alamuddin. Dr. Bun
Yeah,
Shamtan.
I interpret innovation that it new and useful, and it can be approached and or can be model, not the technologies. For our network, this is the new approach that we come as the we don't hire by the network. We are all volunteer working in the countries, and we face the same challenge. And we come together, and then we tell the developing partner that we need this. And you should, we do the people interoperabilities in the regions, and we identify the challenge that we face the same thing, and then we tell, don't give us the silo health information system, not the TB, malaria, HIV, or anything. You have to work interoperability, so the workload will not be as the health provider, and then it will be easy to build the national health information system. So that's what I interpret the innovation, and that is the new approach. And right now we are aligned with the developing partner, and they are investing on the gaps, the governance, the architectures, standard interoperability, and the program management.
Thank you, Dr. Bunshai. Dr. Alamuddin.
Thank you for the question. I think technology is extremely important, but if we look at the innovations in fragile and complex settings, most of those that get the highest yield or return on investment are those that do not really engage technology. I'll give a quick example. In the Syria field office of UNRWA, one of the innovations was to ask the staff to report to the closest center where they can feel safe practicing. They don't have a place of employment anymore. It's flexible. And to work at work hours that follow the needs of the population. So if there's a curfew, you won't be at the center. You wait until the curfew is lifted and you go there. And mobile clinics and other things. So answering your question, I don't think technology is necessarily, should be there for innovation.
Dr. Mirza, especially with your role now with the EMRO office heading the Health Sciences Division.
Well,
Health systems.
one example I already gave you of meningitis vaccine, $0.5 per dose versus $50 per dose. Another example I can give you is that of medicines for vaccine, for hepatitis C. So when the medicine was introduced, for one patient for 1 year, the cost of treatment was around about $80,000. Today in Egypt, when it is locally being produced, the cost is around about $900 for one patient for 1 year. So although it is not developed in Egypt, but simply by through transfer of technology and through local entrepreneurship, the cost of production can remarkably go down, provided at the same time the intellectual property protection can be managed from public health perspective.
Absolutely. Thank you. Questions from the floor? Yes, we have 2 questions. Doctor over there, and then.
First of all, I am Dr. Sudhir Kumar Satpathy. I am heading a School of Public Health in KIIT University in Bhubaneswar, India. I have a lot of interest in global health, and the question I want to ask that we have developed a lot of technologies, but it has no access to the public. So I think innovations we can do while just making it access, technology access to the people. And if we do that one at local level, encouraging local people, local institutions, by that also the cost also can be reduced. So my question is, how far we can go for this operationalizing innovations rather than just concentrating only on producing more expensive technologies?
Excellent questions. So we'll take the other question, then we'll have responses, and we close the session. No, then.
Lady with double glasses. I like it.
Thank you. My question is addressed to Dr. Rawaf. You seemed to say that we should monitor international NGOs in the intervention in fragile settings, but do you have practical examples of how that can be done when social and government systems are broken? I mean, how do you monitor their activity?
This needs a whole session to answer. So we'll take 2 more questions and then we have to break. The lady in the back, gentleman in the front. Prepare quick answers, gentlemen.
Catherine Skank-Iglesias. I'm a demographer, and I'm just interested in the health indicators on, for example, for wellness, percentage of children and adults going for preventive dental visits, things like that. A lot of times when we talk about post-conflict, we're looking at emergency issues, but are we looking at indicators of wellness and as well in the health information systems? Thank you.
Last question, gentleman in the front. Until the mic reaches the gentleman in the front, I do recognize that this is an all-male panel, but I promise you that we have sessions where we have all-female panels just to balance the things. So we didn't forget.
Good morning. I'm Dr. Iyad from URDA, Union of Regional Development Associations. My question is, I'm coming from humanitarian backgrounds, and always it's the question, who will take the responsibility about the healthcare? Is it must be UN or Ministry of Public Health or parents of the children? Who must take the responsibility? When you see a lot of children have a lot of diseases, of malformations, and no one take care of them, who must take care of these people?
I think different type of technologies could be adopted in different ways in different settings. We were talking about, of course, fragile systems, but I think we widen it to all systems in the low and income countries. My talk was specific about fragile countries, but even if you have some sort of stability, as you said, wealth sometimes attract different type of technology, you know. But the situation in a country, technology, for example, in Iraq, which rely on electricity, is absolutely useless. All right? Because it will be of no benefit to the population. Especially, we have home devices technology increases in the last few years in an unbelievable way. In my setting in the UK, it's a mercy for us. It's actually reducing the cost on the health system, giving a freedom to the patient to be actually care after at home in a beautiful way. And it's very cheap technology. If I take it to Iraq, it's useless. Yeah. You know, when 8 or 9 hours of no electricity supply, and despite of billions of investment, and there is nothing clear in the horizon. I'm very delighted that
in Lebanon, this technology is useless, absolutely useless. No electricity at all.
So it become useless technology, you know. Actually, our Prime Minister said we need to develop a new type of batteries which last long, and she invested a lot of money. The issue about NGOs, and I'll shut up. The issue about NGOs, we welcome NGOs. We admire their work. But I think the recent practices, you know, which created a little bit of tension to us. When I mentioned, for example, Bill Gates Foundation or the Gates Foundation, I admire their work. They are doing fantastic work across the world. But when we started, you know, working with them, or when they worked at the beginning to be much more accurate, they believed in verticalization. So they did more damage than good. And we know what happened in West Africa. It's well documented. Just send me your email. We will send you the literature. You know, we looked at it. We sent our team there. You know, they apologized. The man himself apologized. They corrected that. But also in Haiti, we know how, for example, Oxfam misbehaved in Haiti. You know, Dr. Zudat Bandries misbehaved in Haiti. You know, it's well documented. I don't want to remind you. So what I said, that in a fragile system, you have to have international governance. You shouldn't allow people to step in without some framework. Say, look, this is how you work. And national government, this is the most complex question you ask. National governments should take responsibility. The question, when national government is incompetent, what do you do? WHO have a mandate to work with government. How can we exceed that mandate? We say, look, for humanity, we need to do something else, you know? And I have no solution. And I hope Zafar will provide some solution.
Any additional comments? Zafar, go ahead.
I would
We'll
like...
conclude with your comment.
Sorry? Okay. No, I just wanted to respond to this point about a friend who mentioned about humanitarian response and whose responsibility is healthcare. Well, healthcare is a responsibility of national government, as was being mentioned, but let me give you an example. We were recently sitting with the Minister of Health of Somalia, and publicly she said that 99% of financing for healthcare in her country comes from outside. So that's the reality in our fragile settings. But having said this even does not mean that it also takes away the responsibility of the national government. The national government is the custodian of the healthcare of their people. But one additional point which I want to mention is that even in these contexts, however and how much important the humanitarian response is, it is absolutely very necessary, but it is not sufficient. We have to have a development response simultaneously woven with the humanitarian response in order to build what has been damaged and in order to recover from those emergencies and actually lay the foundations of future health systems in these countries. Unless we do this, we will not succeed, and we will continue to be in this rigmarole. I wanted to speak about humanitarian development peace nexus, which is a new way of thinking. United Nations, World Bank, UNDP, everybody is now promoting it. Dr. Naima is sitting here. She's actually part of implementing it in Sudan. That's the way to go about it. And so we're sitting in a university. I think our students need to be taught about it. Thank you.
Thank you. Thanks for the wonderful panel.